طيب دكتور عبد الحفيظ، باقي دقيقة واحدة.
ايوه دكتور اشرف. خلاص تقريبا يعني. ما شاء الله بدأوا الآن بيدخلوا 400 وكذا.
طيب
ان شاء
أعطيني
الله.
بس، قل لي متى نبدأ وأنا جاهز.
طيب يا سيدي ابشر.
شكرا.
هو غالبا اذا وصلنا ال1000 دخلنا، واذا تعدى الوقت دقيقتين خلاص نبدأ على طول.
خلاص تصير 39 دقيقة نبدأ، أو إذا وصلنا
بإذن.
لل أوكي.
اي. ما شاء الله تبارك الله، التسجيل الواقعي اتعدى المطلوب.
نبدأ. طيب نبدأ.
بس كان في اشاره انا عشان يوقف الفيديو.
خلاص خلينا نبدأ الآن.
اي. بسم الله.
طيب، بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. Dear colleagues, respected speakers, ladies and gentlemen, Assalamu alaikum wa rahmatullahi wa barakatuh. First of all, I would like to welcome you here, and on behalf of the IMC Family Medicine Club and the Saudi Society for Family and Community Medicine, it's my great pleasure to welcome you here to the 50th IMC Family Medicine Club session webinar, which is titled with the chronic kidney disease in diabetes, clinical cases and practical consideration for us as a primary care physician. And I'm very glad that we are celebrating today the 50th IMC Family Medicine Club, which was a very long journey that we have started many years ago with a full commitment to bring to you the updated informations, clinical guidelines, clinical expertise, not only from family medicine qualified professionals, but also from different perspective and different specialty that complement our work as a family physicians. So today's sessions, ladies and gentlemen, will bring together experts and healthcare providers because the topic is quite unique today. So we are going to have along with us family physicians, endocrinology, nephrology, cardiology, internal medicine, and other specialties, in fact, who are so much engaged in managing patients with diabetes and chronic kidney disease. And as we know, diabetes remain one of the leading causes of chronic kidney disease globally, with a special focus here in this part of the world in the Kingdom of Saudi Arabia. So our role to enhance our competency in early detections and timely interventions in primary care setting will have a significant impact on reducing the complication and improve, in fact, the quality of life, because nowadays we are talking about a very new concept in our healthcare system, which is the quality of life, longevity, population health, and lifespan. So we would like to maintain the quality of life for those patients with diabetes and chronic kidney disease. So this webinar will aim to bridge the gap between two important entities that always constitute a challenge for us: the evidence-based recommendations and the real-world clinical practice. So this will be highlighted. So I will just remind you with our objective today that we are going to highlight the importance of early identifications and screening for chronic kidney disease in patients with diabetes. What is the importance of early intervention and screening? And the other thing is we're going to discuss the practical case-based approach for management of chronic kidney disease in diabetic patients with our colleague who's representing the endocrinology. So, and then we are going to identify how we can collaboratively communicate together with different specialty between the primary care and the specialty to optimize our patient approach and to optimize the patient-centric approach. So, ladies and gentlemen, today we have been privileged to have with us a very, very, very distinguished speakers, in fact, Dr. Abdullah Al-Ghamdi and Dr. Ahmed Al-Sumaili, who will share with us their own expertise and the valuable clinical insight in this kind of these presentations. And I would like also to extend my sincere appreciation to Bayer Company for bringing all of us together here to share knowledge and to exchange experience on managing patients with diabetes and chronic kidney disease. So thank you again for all of you to join us today. And I hope that it will be a quite engaging and informative and interactive session. So before I close, I would like just to remind you all to keep your questions in the Q&A box, so I'll be able to identify the appropriate question to be delivered to the two speakers at the end of the session. So without any further ado, I would like to introduce our first speaker, Dr. Abdullah Al-Ghamdi, who is a very dear colleague of mine. He's a family medicine consultant, CPD supervisor at Family Medicine Department, Family Medicine Program Trainer, Security Forces Hospital in Riyadh. So he's going to start as a family physician to tell us how he approached the patient and how he could identify early identifications and screening of chronic kidney disease in patients with type 2 diabetes in primary care. So, Dr. Abdullah, we are very pleased to have you with us here today, and I would like to thank you for accepting our invitation and to be part of this fruitful meeting, inshallah. I will leave the floor for you. Looking forward to hear from you.
Okay. Good evening. Assalamu alaikum, everybody. Thank you for you, Dr. Ashraf, and for the organizers. I'm trying to start sharing my.
Share the screen. Yeah.
Okay, to share screen, just screen. I have a problem. Just 1 minute. Tap on screen. There is an issue for screen.
So
screen sharing.
Dr. Ahmed, you might need to stop sharing.
That's the problem. Yes. I cannot just screen. Is it clear now?
No, it's not clear. It's not yet there.
Not clear. What happens? Everyone in your screen.
You have the share button.
Yeah, there is, but why it's not working?
طيب. I think you close it and open it again, Dr. Abdullah.
Okay, I will close the Zoom.
Yeah.
Okay. Okay, it's coming. Just yes.
Yes, I think it's
Yes.
coming.
Okay, let's start. Sorry for this delay. Okay, as Dr. Ashraf said, CKD in diabetics is a major health issue. And just I will talk shortly, almost for 15 minutes, about the clinical cases and, sorry. Okay, screening and identification of CKD in patient with type 2 diabetes in primary care. So first slide, just to tell us about the prevalence of type 2 diabetes. As you see, the number of patient in 2021, almost 537 million globally, almost 10.5% of global population. Expected to be as high as 783 million in 2045. For this prevalence, this 2021, 190 million of these patients, diabetic patients, have CKD diseases. We know, all of us, that type 2 diabetes represent almost 90% of diabetic patient, almost 10% only for type 1. On your right side, you see the prevalence of CKD globally. It's almost 8.7%. So it's a huge, both of them, they are a huge health issues. This is in MENA regions. As you see, the number of patients, almost 85 million diabetic patients in MENA regions, Middle East and North Africa, expected to be doubled almost in 2050. So it's a huge problem. And in Saudi Arabia, almost we have 5.3 million patients, expected to be 9.5 million in 2050. As you see in our region, in MENA region, the number of patients, the prevalence increasing every year, and with time it will reach, as we said, almost doubled in 25 years. Other comorbidities we see in our patient in MENA region and also in our region, as you, maybe of all of you, when you see diabetic patient, we have other comorbidities. It doesn't come alone almost. So most of our patients, they have high LDL, CKD diseases, and cardiovascular disease. LDL alone almost comes as 90% in our patient, 44% CKD, and cardiovascular disease almost 17%. As you know, all of you, that diabetes is the leading cause of kidney disease globally. Morbidity of CKD, almost diabetic patient, especially starting at the late 40s, as you see the yellow bars on your sides, right side. This is representing type 2 diabetes. So with time, that global prevalence, as we said, is very huge. It's almost 9.1. The number of patient or the prevalence globally, almost 700 million patient. Most of them, the leading cause, especially in the ages after 45, they are diabetic. And as we, diabetic and CKD, they lost almost 23 or almost quarter of their healthy years because they have kidney disease with diabetes. This is the cost. Of course, the diabetic care, healthcare, it's very costly. This is in 2018, as you see on your left side. This is in America for patient with diabetes and CKD. Almost the cost was $21 billion per year. This is for patient only with diabetic. CKD, they are more than 66 years. And as the diabetes alone care or diabetes with CKD, diabetes with CKD almost cost 50% extra. On your right side, you can see the cost of kidney failure or renal failure in Europe almost cost 40,000 euro per year, per patient per year. So it's very costly disease, and it needs, and the cost increase with years. You see these three circles, we know now almost kidney disease, diabetes, and heart failure. They have a common risk factors, and these three diseases are interconnected. If you see now the three circles, CKD, heart failure, diabetes, they are overlap in some areas and they are interconnected. Now, like if you have diabetic patient, they are prone to have CKD. If you have CKD patient, they are prone to have heart failure. If you have patient with heart failure, he is prone to have worsened CKD and like this. So they are interconnected. They have shared risk factors. And as you see, the risk factor common for all these three diseases, we have three major risk factors like obesity, inflammation, vascular diseases. And for CKD and diabetes, we have common risk factors like diabetes, for diabetes and CKD, we have common risk factor like older ages, male sex, hypertension, and smoking. So just from this slide, we know now those three diseases are very interconnected. This is the journey of the patient, starting from the beginning at the early stage of discovering the diabetes patient. The early stages started almost in primary care with family physician. So if the family physician not aware about this problem, they will not screen. And we will see now how much is underestimated. And the screening for CKD is underestimated globally, not only in our country. So our role as a family physician at the first stage, before symptoms, screening is starting very early, even at a stage, screening before symptoms at all. So we can detect the patient at early stages of CKD or stage 2 maximum. So if we start earlier, we can protect and prevent a lot of complications. So KDIGO 2022 in their guidelines highlight the importance of coordinated care for patients with type 2. It's not a matter now of lowering glucose only. It's a holistic, coordinated service. So it includes all specialties, not only the physicians including family medicine, cardiologists, nephrologists, internists, everybody, but even the pharmacy, the educators, everybody, they have a role in taking care for diabetic patient. Of course, the management should include pharmacological therapies for targets and for lowering hyperglycemia. All glycemic control also important, lifestyle intervention. So it's a comprehensive. Our goal at the end to promote self-management for patient to understand how to manage himself. And this should be done by a team-based care. We should use organ protective therapies. Now we know that we have many groups of medication that targeting cardio-renal protection. So it should be used properly, and coordinated or holistic approach is very important. This is a ADA recommendation for multifactorial approach to reduce the risk of diabetes complications. As you see on the left side, this pyramid, so start with the lifestyle modification and diabetes education, treating glycemia, blood pressure, lipids, using agents that have cardio-renal protection like SGLT2, non-steroidal MRA, GLP. So this is the ADA, all of us, we know that this is the latest recommendation to use medication that are cardio-renal protective. As you know, all of you, the effect of diabetes on different organs, almost it affects all organs because it's attacking or affecting nerves, vascular system. So it causes a lot of complication, retinopathy, nephropathy, neuropathy, cerebrovascular, cardiovascular, peripheral artery diseases. So when we have diabetic patient, we will ask ourselves, does that patient have heart failure, CKD, atherosclerotic cardiovascular disease, or he have a high risk for cardiovascular disease? Why we should know this? Because we should take care of a holistic approach, as we said. We should take care of all these disease, and we should target our management to these problems. And as they said in the AASD consensus, that it's the best approach for management is to use the patient-centered care. The patient should be a main if he should be involved in his management. So patient should be the decision of treatment should be taken with the patient. So shared decision should be made, and everything explained, the comorbidity for the patient, the medication, and the organ protection. Explain the medication for for him, benefits, safety, and risk. So if you involve the patient with you in management, the outcome will be much better. This is just to remind us, if the patient have type 2 diabetes with CKD, how much it will be higher to get more cardiovascular event. As you see in the first row up, how much he will get more MI cases, 2 times almost, heart failure 5 times, hospitalization from heart failure 2 to 6 times, cardiovascular death 3 times more than if he is diabetic alone. The second column, you will see the use of healthcare services if the patient have type 2 diabetes alone, or if he have with high albuminuria, you will see that he will use ER services 2 to 4% more, and he will get inpatient or admission 4 to 10% more than if he is diabetic alone, and he will get in the future dialysis and hemodialysis 4 to 40%. So early detection here and intervention are crucial. Now, all major scientific societies now recognize the importance of identifying and managing CKD in patients with type 2. I think nobody now disagree with this recommendation. Like ADA now, they recommended strongly to screen for CKD. Also European Society for Cardiology, because we will see in next slides how much it's important to screen, not to protect only renal or even cardiac risk. KDIGO also they highly recommend screening. ADA KDIGO consensus also. So now it's guidelines, almost European, American, they all recommend screening of CKD. This slide is very important just to see. In the left side, you will see the heart. This is the heart shape here. Because as I said previously, that it's now not to protect only renal, also to protect heart. So cardiovascular risk increase also. When you get CKD, the risk of cardiovascular disease will increase. So it start as early as 10 milligram per gram. The risk of cardiovascular can increase before even we get high GFR or the damage. We know that early starting with the damage of the kidney, and later on the function will be affected. GFR, the function, before it starts, we can early detect the damage by albuminuria. We will talk later. So this is the two composite of the cardiovascular composite and the kidney composite. If you see that they are almost have the same shape. If the albuminuria getting higher, so the events of cardiovascular and kidney, you will see with time as higher albuminuria, CKD, so the higher will be the cardiovascular events. Here just to see the cardiovascular mortality if the patient have CKD with type 2 diabetes. See if the patient on the left side have nothing, no diabetes, no CKD, the mortality from cardiovascular event almost 3.4. Type 2 alone, the mortality from cardiovascular disease 6.7. If the CKD alone, it's even hard alone. It's higher than diabetes. It's almost 10%. If CKD with type 2 diabetes, the percentage goes to 20%. So it's a very huge number and increase. Just if the CKD and type 2 diabetes together, the mortality from cardiovascular disease will be almost 6 times the normal. This is the underestimated, I told you, that globally there is a problem in screening for CKD. So this is some studies in different countries. As you see, the best country in screening may be UK. Next is the Netherlands, USA, then France. So this is, sorry, we don't have any local, I couldn't cross any local studies, but this is, will tell us globally there is a problem in detecting or screening for CKD. This also the same issue underestimated. If you see the albuminuria in yellow, in blue color, and the low GFR in yellow color, if you take the GFR as indicator of CKD alone, so you will miss a lot of patients. So you will underestimate the CKD. This is the test to use. Now it's almost before we are talking about 24 hours urine collection. Now it's not recommended as screening. We are using now urine dipstick or urine sample spot. And we are testing for UACR, urine albumin creatinine ratio. And to be positive, we should have 2 readings out of 3. If you have 1 positive reading, you should repeat within 3 to 6 months. If you have 2 positive readings, this is positive for albuminuria. But we should be cautious. If you see the precautions down, just to take care when the sample taken, if the patient have exercise within 24 hours or infection, fever, congestive heart failure, the microalbuminuria may be higher. So you should repeat. That's why we are not taking only 1 reading. So we need another reading, and we should take care of those factors that increase microalbuminuria. This is all of us now. We are used to see this table everywhere, the KDIGO heat map. This is the ADA now. They are adopting KDIGO referral for CKD. As you see now, this red box, screen and treat, almost this is our patient in family medicine, in primary care. So all those patients we can screen and treat in family medicine. This is not mandatory for everywhere. I don't know, some institutes, they have different guidelines for referral to nephrology. Some institute even they are only refer patient if he is G4. But this is the ADA adopting this KDIGO referral guidelines. How to improve? What are the opportunities to improve early CKD diagnosis? We have 3 levels, of course. Patient himself, if they have better access for patient education, if they know that the early stages of CKD are asymptomatic, they will ask for screening. The second level, healthcare providers, of course, if they have clear guidelines, and if they have supportive technologies like now electronic systems that remind about the screening, about CKD, if the patient have high albuminuria, it can give alert. They have electronic system to calculate EGFR. So all these factors can improve the screening for CKD. Third level, the healthcare system itself. So I think if they have the clear referral pathways, and if they can, of course, this is incentives are very important. If improved, it can improve the screening. So just 4 points to summarize my talk. 4 very important points. CKD is asymptomatic in early stages. So detecting early CKD is very important. CKD can easily be detected with simple, low-cost and accurate test, which is urine albumin creatinine ratio. Certain patient groups are known to have higher risk. we talk about diabetes, heart failure, hypertension. All those patients, they are more prone to have CKD. Evidence-based interventions are available now. KDIGO guidelines is very clear, and most of the institute, most of the world, they are adopting KDIGO guidelines because it's very clear and straightforward to slow progression and reduce its complication. Thank you very much.
Thank you very much, Dr. Abdullah, for the nice conclusions, which was very summarized, and you have shed light on the early identification and screening of chronic kidney disease in type 2 diabetes patient with a special focus on the primary care. So thank you so much. And now we'll move, ladies and gentlemen, to the second guest speaker, who is Dr. Ahmed Al-Samiri. He's a consultant and head division of adult endocrinology and diabetes, National Guard Hospital in Riyadh, and the chairman of the outpatient department. He's going to complete our journey to identify our role as a primary care physician in the journey of patient with diabetes and chronic kidney disease. So he's going to shed light on the practical management of chronic kidney disease in type 2 diabetes, case-based approach for primary care. So thank you so much, Dr. Ahmed, for accepting our invitation and being part of this scientific gathering. Looking forward to hear from you. And it was very interesting to know from Dr. Abdullah that still as a primary care physicians, we can manage stage 1, stage 2, stage 3A. So this is quite appealing, quite encouraging, and quite promising, in fact, for all of us. So I will leave the floor for you, Dr. Ahmed, just to complete the remaining part. The floor is yours.
Assalamu alaikum. Thank you, Dr. Ashraf. Thank you, Saudi Society of Family and Community Medicine. And thank you also, IMC, Bayer also, who's the sponsoring of this great events, actually. So my talk tonight will be about practical management of CKD in type 2 diabetes. So as a continuation of Dr. Abdullah talk, I will start first of all by a case from practice, which is actually is a common case. You're seeing it in your practice, either in primary healthcare clinics or even in endocrinology or tertiary secondary centers. So this case is a 58-year-old patient with type 2 diabetes for 12 years. She's hypertensive, hyperlipidemic, and no history of dialysis or renal replacement therapy, and persistent poor glycemic control despite therapy, and evidence of early diabetic kidney disease. Her current medications: long-acting insulin, dapagliflozin 10 milligram daily, sitagliptin 100 milligram daily, antihypertensive therapy, which is including angiotensin converting enzyme inhibitors, and statins therapy. These are her profile. So investigation showing A1C about 8.3, eGFR around 50, with urine albumin creatinine ratios around 120 milligram per liter, with a potassium 4 and sodium around 135. So interpretation of findings: the patient demonstrates suboptimal glycemic control, chronic kidney disease stage G3A, and you did see the map, which is presented by Dr. Abdullah. So this patients with regard to eGFR and albumin creatinine ratio, so showing a stage G3A, albuminic diabetic kidney disease, high cardiovascular and renal risk profile. So the combination of diabetes, hypertension, albuminuria, reduced eGFR suggests evolving cardiorenal metabolic disease. The clinical decision: so main objectives: slow chronic kidney disease progression, reduce cardiovascular risk, improve glycemic control, reduce albuminuria, preserve long-term renal function. And the management approach: so for sure to continue SGLT2 inhibitors, which is dapagliflozin, and was continued because proven renal protective benefit, reduce albuminuria, slows eGFR decline, reduces hospitalization for heart failure, and independent cardiorenal benefit beyond glucose lowering. Second step: optimize RAS blockade, initiate or optimize angiotensin converting enzyme inhibitors or ARBs therapy. Goal to reduce intraglomerular pressure, lower albuminuria, delay CKD progression, and monitoring, which is by creatinine, potassium, and blood pressure. And third step, improve glycemic control, which is we need to target an A1C less than 7% by options considered basal insulin titration, consider replacement or replacing sitagliptin with GLP-1 receptor agonist if appropriate. Benefits of GLP-1 receptor agonist: cardiovascular protection, weight reduction, and additional renal benefit. Blood pressure optimization for sure, to target a blood pressure less than 130/80. And also lipid management, continue high intensity statins, address overall atherosclerotic cardiovascular disease risk reduction. What's the justification? This patient represents a typical modern cardiorenal metabolic syndrome phenotype. Despite relatively preserved EGFR, the presence of albuminuria, long-standing diabetes, hypertension, elevated A1C places the patient at substantial risk for progressive chronic kidney disease, cardiovascular events, heart failure, and end-stage renal disease. So early intervention is critical because albuminuria is an early marker of both renal and cardiovascular damage. Current ADA and KDIGO guidelines or recommendations strongly support SGLT2 inhibitors, RAS inhibition, non-steroidal selective mineralocorticoid receptor antagonists, multifactorial risk reduction to delay disease progression. At 1 month, potassium 4.1, blood pressure assessment also. At 3 months, hemoglobin A1C must be less than 7, which is 6.9. Urine albumin creatine ratio around 50, EGFR 60, and potassium is 4.2. At 6 months, repeat renal profile, albuminuria trend down, lipid profile control, and control LDL, evaluate progression and treatment response. So conclusion and learnings from the case. This case highlights the importance of early recognition of diabetic kidney disease, albuminuria as a major prognostic marker, the shift from glucose-centric management toward cardiorenal protection. Key learning points: multifactorial management is essential. CKD can progress even with near normal creatinine. Early aggressive intervention improves long-term outcomes, and the management of type 2 diabetes today extends beyond glycemic control toward comprehensive cardiorenal metabolic protection. So from this case, just to show our traditional treatment and how we follow these patients usually, and when we intervene and when we start or higher the doses of treatment, and when we intensify the treatment, and what's missed in this case. So we'll mention that later. So limitations also exist in our current approach to the management of CKD and type 2 diabetes, as you see here in Credence trial. So canagliflozin versus placebo, also DABA CKD and IMBAS kidney, all still there is a persistent risk or residual risk of chronic kidney disease in a patient who has albuminuria or low EGFR. CKD progression in type 2 is driven by combined effects of metabolic, hemodynamic, and inflammatory and fibrotic factors. So as you know, CKD, there is a multiple factors that affect the kidney, which is either hemodynamic like blood pressure, or hypertension, metabolic like poor glycemic control, and inflammation and fibrosis, which all lead to chronic kidney disease progression. In this slide, just to show the effect or the benefit of RAS inhibitors, SGLT2 inhibitors, also GLP-1 receptor agonist, and our new guest, which is finerenone or non-steroidal MRA. So RAS inhibitors, as you know, decrease afferent arterial tone, hyperfiltration, endothelial dysfunction, and cardiac remodeling. And also SGLT2 inhibitors increase afferent arterial tone. And also all these two medications, or two types of or groups of medications, cause hemodynamic perturbations. And we know GLP-1 receptor agonist also can cause metabolic regulation in a patient who have metabolic dysregulation. And finerenone will decrease inflammation and fibrosis by fibrosis, endothelial dysfunction, and tissue remodeling, and proteinuria. So, mineralocorticoid receptor overactivation blockade with finerenone slows kidney and cardiovascular disease progression. So here just to show mineralocorticoid receptor overactivation, blockade, and hemostatic action will lead to inflammation, fibrosis, and hemodynamic also factors, and this will lead to reduction of cardiovascular and kidney event. Finerenone is a distinct, selective, non-steroidal MRA, pharmacologically differentiated from available steroidal MRAs. So what we know available steroidal MRA like spironolactone. So the structure it's flat in spironolactone while it's bulky in finerenone. Selectivity for mineralocorticoid receptors is high selectivity with finerenone, while it's low with steroidal MRA. And sexual side effects, as we know, is higher with aldactone, spironolactone, not with finerenone. Half-life is around 2 to 3 hours, while in aldactone, spironolactone is more than 20 hours. Tissue distribution, kidney more than heart, while in finerenone it's equal in kidney and heart, which is balanced. The indications, spironolactone indicated for congestive heart failure, NEHA class 3 and 4 heart failure, while in finerenone, in United States, finerenone is a non-steroidal MRA indicated to reduce the risk of sustained eGFR decline in the stage kidney disease, cardiovascular death, non-fatal MI, and hospitalization for heart failure in adult patients with CKD associated with type 2 diabetes. In this slide, showing the four pillars of treatment or pillar approach is aligned with the multifactorial and holistic approach for the treatment of CKD and type 2 diabetes recommended, which is recommended by ADA and KDIGO guidelines respectively. So the ADA 2024 guidelines recommended reducing albuminuria levels to slow chronic kidney disease progression, and treatment recommendations is 11.6, level of evidence is C. So in people with CKD who have more than 300 milligram per gram urinary albumin, a reduction of more than 30% urinary albumin is recommended to slow chronic kidney disease progression. Maybe this is the map that was shown by Dr. Abdullah, and here is just showing the benefit of adding finerenone or decreasing by 30% urine albumin creatinine ratio. So, and this will the reduction more than 30% cause in urine albumin creatinine ratio may be required for some people to reduce their risk of CKD progression from severe to moderate chronic kidney disease. In this slides or coming few slides, we'll talk about Fidelity trial, which is included 13,000 patients. Fidelity study, which is Fidelio diabetic kidney disease, Figaro diabetic kidney disease, around 13,000 patients as mentioned, 6,500 from them on finerenone 10 or 20 milligram, and around 6,500 on placebo with a median follow-up of 3 years. These are the inclusion criteria: more than 18 years with type 2 diabetes and eGFR between 25 to 90, or urine albumin creatinine between 30 to 300, or eGFR more than 25 with albumin creatinine ratio more than 300, and potassium less than 4 or equal 4.8, maximum tolerated dose of ACE or ARBs for more than 4 weeks, excluding heart failure patients, uncontrolled hypertension, and A1C more than 12, and non-diabetic kidney disease for sure, stroke, TIA, acute coronary syndrome, or heart failure, and urine albumin creatinine ratio more than 5,000. So here is finerenone has demonstrated a significant reduction in cardiovascular and kidney outcomes in 2 phase 3 clinical trials. So the Fidelity pro-specified pooled analysis of data from these 2 trials, as I mentioned, more than 13,000 patients, so 14% reduced risk of cardiovascular morbidity and mortality, reduced also risk of first heart failure, 23% also reduced in risk of chronic kidney disease progression, and 20% reduced risk of end-stage kidney disease. So 32% reduction of albumin, urine albumin creatinine ratio with finerenone. In this slide, also just to show the adverse effects and also safety of finerenone and incidence of hyperkalemia. So incidence of adverse effects and changes in vital signs were similar between finerenone and placebo. It's almost similar in any adverse effects, acute kidney injury, systolic blood pressure, and gynecomastia, and no change in A1C. A holistic approach to treatment is recommended by KDIGO 2024 guidelines for improving outcomes in patients with chronic kidney disease and type 2 diabetes. As you know, and your familiar lifestyle is very important. And then first line drug therapy for most of patients, controlling either blood pressure, controlling blood sugar, and also lipid. So in controlling blood sugars, SGLT2 inhibitors is very important to continue until dialysis or transplant, and treated therapy for complications, manage hyperglycemia as per KDIGO diabetes guidelines, including use of GLP-1 receptor agonist. Controlling blood pressure is very important, starting RAS inhibitors at maximum tolerated dose, and then if not controlled, use non-steroidal MRA in people with diabetes, and an indication for use in cardiovascular and kidney disease. And also calcium channel blockers can be added to control the blood pressure, and also steroidal MRA if not controlled if needed for resistant hypertension, and if eGFR more than 45. Statin therapy is very important to control lipid, and this is very important also for cardiovascular risk. These are the all guidelines which recommended again treating patients with diabetes and chronic kidney disease, either starting with ACE/ARBs. Non-steroidal MRA is very important to add in all these guidelines mentioned, and also SGLT2 inhibitors, GLP-1 receptor antagonist is important also. Also, European Society for Cardiology 2023 guidelines for the management of cardiovascular disease in patients with diabetes to reduce the cardiovascular risk and to reduce kidney failure risk. Again, statins-based regimen, ACE or ARBs, and to reduce cardiovascular and chronic kidney disease, finerenone class 1A, SGLT2 inhibitors class 1A, blood pressure control is class 1A. And 2023 focused update of 2021 European Society for Cardiology guidelines for the diagnosis and treatment of acute and chronic heart failure and prevention of heart failure in CKD and type 2 diabetes. Finerenone is an important as class 1A, and also SGLT2 inhibitor as class 1A. 2026 ADA guidelines. So the newest guidelines in CKD patients, finerenone is recommended in patients with CKD and albuminuria to reduce cardiovascular events and CKD progression if eGFR more than or equal 25, and potassium level should be monitored. Also, cardiovascular disease, finerenone is recommended in patients with type 2 and CKD to reduce the risk of heart failure. And this one is, as we mentioned, the level of evidence is 11.9, simultaneous initiation of SGLT2 and non-steroidal MRA can be considered in adults with type 2 diabetes and urine albumin creatinine ratio more than 100 milligram per gram with eGFR 3290, and on RAS inhibitors due to evidence of safety and beneficial effect on albuminuria. Time for the new approach to management of CKD and type 2 that prioritizes accelerated therapeutic implementation. As we know, traditional approach was in 3 months to assess the patient every 3 months, and then at 6 months to add non-steroidal MRA. Accelerated approach, 3 months starting ACE, and then SGLT2 inhibitors, and after 3 months starting a non-steroidal MRA, GLP-1 receptor agonist, and then titrating the dose to reinforce adherence and risk factor control. The rapid sequence approach, which is adding ACE or ARBs, SGLT2 inhibitors, also can be added to this regimen, non-steroidal MRA, GLP-1 receptor agonist, and then in 3 months, titrate dose, reinforce adherence, and risk factors control. So what could be potential benefit of simultaneous start of combination therapies in CKD? Quicker and greater urine albumin creatinine reduction, improved kidney protection, increased target of urine albumin creatinine ratio achievement, potential for improved cardiovascular outcomes, gaining time for patients, simplifying practice, and addressing clinical inertia. So, risk of progressive or progression to kidney failure, heart failure, and death can be dramatically reduced with combination therapy. And as you see here, anticipated event-free survival with optimal kidney therapeutics in people with diabetes and CKD, heart failure, all-cause death, kidney failure, and composite kidney outcome, all with combination therapy will be much better. So 17 years to get evidence into practice, opportunity to gain many events, 3 years will have been lost. So results from cross trials analysis suggest a potential cardiovascular benefit with SGLT2 inhibitor, GLP-1 receptor agonist, and non-steroidal MRA combination treatment in patients with type 2 diabetes and albuminuria, all showing in MACE and heart failure combination in favor of combination, heart failure in favor of combination, and cardiovascular death in favor of combination therapy. Again, chronic kidney disease progression in favor of progression in favor of combination therapy, and also all-cause death mortality or all-cause mortality in favor of combination therapy. So a better approach combining therapy with these types of treatment in addition to RAS blockade may be beneficial for patients with type 2 diabetes and albuminuria, as these drugs target different complementary pathophysiological pathways involved in cardiovascular and kidney diseases. So a greater reduction in urine albumin creatinine ratio with combined use of finerenone and SGLT2 inhibitors among patients with CKD, retrospective analysis of patients from United States, specialty CKD clinic. So proportion of patients with more than 50% reduction in urine albumin creatinine ratio in favor of, again, combination. And again, also same percentage of reduction in urine albumin creatinine ratio from baseline, and change in potassium also they're showing no change from the baseline or reduced risk of hyperkalemia with combination. Confidence in trial, so overview of K efficacy was showing both primary endpoints were achieved in greater reduction in albumin creatinine ratio, greater reduction in urine albumin creatinine ratio in 180 days with combination than finerenone, also with combination therapy than empagliflozin. So absolute reduction is around 52% at day 180, 30% at day 14. So when initiated simultaneously, the safety profile of finerenone and SGLT2 inhibitors was largely consistent with that of either agents alone. Practical use of for the initiation and monitoring of finerenone. So indications type 2 and CKD with a serum potassium less than 5 and eGFR more than 50. Dosing is starting with 10 milligram if eGFR more than less than 60, and if it's more than 60 we'll start with 20 milligram, and treatment can be maintained in patients with eGFR more than 15. And dose adjustment, adjust the dose when the serum potassium more than 5.5 with whole treatment, and restart at 10 milligram when serum potassium less than 5. If serum potassium less than 4.8, maintain 20 milligram or increase to 20 milligram if the patient's on 10 milligram. If serum potassium between 4.8 to 5.5, maintain current dose, and monitoring potassium must be remeasured in 4 weeks after starting treatment, restarting of treatment, or dose increase. So act early, screen systematically, treat decisively, collaborate purposefully, and integrate routine urine albumin creatinine ratio screening, initiate guideline-directed therapy early, adopt rapid combination strategies, engage multidisciplinary teams to slow CKD progression and improve cardio-kidney metabolic outcome. And thank you.
Thank you so much, Dr. Ahmed, for highlighting the practical management of CKD using finerenone and SGLT2 and others. So I would like to request both speakers to be on the screen so we can start the questions. In fact, inshallah, we have more than 773 participants attended the presentations, and we have a good number of questions highlighted by some of the physicians. So first question for you, Dr. Abdullah, how do you approach patients when need to introduce SGLT2 inhibitors and finerenone, especially in patients who are worried about polypharmacy? It happens many of the time that patients are resistant. They don't want us to start medication in spite of having a very solid evidence that they have a disease, for example, chronic kidney disease, but they are resistant. How's your approach those patients? How do you convince them?
Yes, great question. Thank you very much. This is a great dilemma. Really, with our patient to add more medication is very difficult. So that's why the relation with patient and shared decision with patient is very important. When you explain to the patient the importance of the problem, the magnitude of his problem first, and the effect of the diabetes on his organs, like cardio, renal problems, all those problems. What will happen if you explain clearly and you explain everything, the side effect, the benefit of the medication, and you try your best to give medication, very important, combination if you can. So I think the shared decision with the patient is very important. Most of the patient they agree if they understand. So this is what I know, and even if they didn't accept first time, next time just tell them again that you need this. With time, most of them they will accept. So I think shared decision with the patient and explain to him every point and answer all his questions. This will solve a lot of issues.
I totally agree with you, Dr. Abdullah, because in our clinical setup as a family physicians, we try to build a good doctor-patient relationship that based on professionalism and trustworthy. And many times in my clinic, when I confront with this kind of issues, we are encountering some patients who are highly educated, but they are resistant. I show them the clinical data and the clinical trials and even the graphs to show them how much is the benefit they are getting of reductions of microalbuminuria and improvement of the EHFR by using finerenone and SGLT2 inhibitors. I assume that they are so competent enough to understand exactly what I say because they are highly educated, so they can. And of course, nowadays we have also the multidisciplinary teams. So we have some other educators and people who can support us with additional education setup for those patients. Thank you, Dr. Abdullah. Dr. Ahmed, you emphasizes on very important approach, which is the rapid sequences of combinations. So what is the profile of those patients who mandate to have this kind of RAS, SGLT2, and finerenone together?
Yeah. So I think any patients with diabetes and having any kind of chronic kidney disease, either with low eGFR or who has also elevated albumin-creatinine ratio above the normal range. So we need to intervene as soon as possible. So usually our patients have uncontrolled blood sugar. Also, our patients have uncontrolled blood pressure. So we start RAS immediately, and after 4 weeks, if it's still blood pressure not controlled or albumin-creatinine ratio still elevated, so we need to add or intervene immediately, adding finerenone or other kidney protective medications, which is SGLT2 inhibitors.
Excellent. Well said, Dr. Ahmed. Dr. Abdullah, a question for you from one of the audience. It said, if you could change one aspect of the current chronic kidney disease management and type 2 patients' care, what would have the greatest impact in the clinical outcome? Knowing that the current practice of our physicians in primary care, what initiative you would like to make this kind of impactful on keeping primary care physician competent to manage patients with chronic kidney disease? Where is the pitfalls and how we can manage it?
Okay, this is, I think it depends on the system. It's not physicians' awareness and, the guidelines, the clear guidelines is very important. The problem that the healthcare system sometimes they don't have even the basic medication for CKD management, and this is a big issue. So a lot of physicians they say we don't have finerenone or non-steroidal MRA, we don't have SGLT2, we don't have GLP. So they have most of the issues that the availability of the medication, the clear guidelines for the physician. I think it will be very easy to manage early stages as an KDIGO heat map. The early stages, even in our hospital, we are treating up to level 3G 2, so B. So it depends on your institute and the availability of medication and clear guidelines and the privileges of the physician. If they improve it, I think there will be a better management for CKD.
I think, Dr. Abdullah, as a family physician, also we have witnessed a paradigm shift in our practice as a primary care physician. I remember 20, 30 years ago when we started family medicine, or even as a general practitioners, we are so limited to treat upper respiratory tract infections and gastroenteritis. But
True.
nowadays, in the last 10 years, there was a very huge paradigm shift that we are competent and enabled to manage patients in the more advanced cases, like chronic kidney disease, migraines, and even other conditions. So we have the smart molecules, we have the perfect guidelines to follow, and we have the availability of those medications and the quality of patient that we would like to have. So I think this is now it's a call for actions to improve our scope of services as a primary care physician and go one step above what we do, and to make sure that we can handle patient with diabetes and complication of diabetes. One of it is a chronic kidney disease. We can do it perfectly with a full confidence because medications are efficacious, safe, durable, and even accepted by the patient if they are willing to have it. So finerenone, SGLT2, RAS inhibitors, and GLP-1, they are the pharmaceutical tools that we have it very commonly available in our clinical practice. Thank you so much. So,
Totally agree.
Dr. Ahmed, I think Dr. Ahmed, you agree with us, right?
Yeah, sure. I think
Okay.
family medicine physicians, they are first line physicians, or I think they're very important to start treatment in primary healthcare clinics, combination treatment, and as I mentioned, rapid sequence treatment will be for sure by primary healthcare physician much better than tertiary centers or secondary centers.
Absolutely, absolutely. In my practice in IMC International Medical Center, we have a healthy relationship between the primary care as a family physician and the secondary care as an endocrinology and nephrology. So we treat patients with stage 1, stage 2, stage 3A, and the other stages will go to the nephrology. So we have shared half of the pie equally between primary care and the secondary care with a full confidence. Alhamdulillah, and the results are quite impressive. So we all agree on this. So, Dr. Ahmed, I was thinking about a condition. Now we are talking about diabetes and chronic kidney disease, but there is a very compelling evidence and a strong evidence that even pre-diabetes has also a complication of chronic kidney disease. So do you recommend using the same modality of RAS, SGLT2, and finerenones in those patients with the pre-diabetes with the evidence of microalbuminuria?
Yeah, so usually pre-diabetes patients is or pre-diabetes itself is a consequence of metabolic syndrome in general, which is including hypertension, also elevated triglyceride and lipid, and also risk of diabetes. So all of these we are talking about cardiovascular mainly. So cardiovascular risk. So we think also early intervention with the RAS is very important. Adding also SGLT2 inhibitor it might be also very important. But adding finerenone in these patients with without chronic kidney disease and without evidence of type 2 diabetes, I think still from my practice, I don't recommend currently, but we don't know in the future, can we deal with pre-diabetes and chronic
Yeah.
kidney disease as diabetes?
I think it's coming, because it has been proven that pre-diabetes associated with a microvascular and macrovascular complication, even cardiovascular mortality as well as, and it's an early onset, which takes about 4 to 7 years before the full-blown picture of diabetes. So that stage become almost like, it's not a pre-diabetes, it's a full-blown disease with with symptoms and complications and burden on the quality of life of patient and burden on the healthcare system with financial and so forth. So I think it's coming.
Yeah.
Okay, I think, Dr. Ahmed, there is a quite frequent questions coming to me from the audience. It's all, I will conclude it with the question: how common is hyperkalemia with combined usage of ACE, ARBs, and non-steroidal MRSA? This is from Josie Bollins.
Yeah.
Dr. Josie's very good question, I believe. Yes.
Yeah, it's
Dr.
a
Ahmed,
great
تفضل.
question. Yeah, and also we talk about it, a combination of SGLT2 inhibitors, RAS and firinone, or non-steroidal mineral corticoid receptor. It was almost same as starting treatment with RAS inhibitors or only starting with firinone. So still very safe combining these medications and almost is same as only one agent.
Okay, perfect. I think, Dr. Abdullah, from your own clinical experience, a question comes, can we initiate SGLT2 inhibitors at the same time with ACE inhibitors? What about increasing creatine level? This is from Dr. Muhammad Ahmed. So
Okay.
your answer?
Yeah.
Yeah, we can.
Yeah, I think now we have the Dr. Ahmed. He mentioned how three way to start the medication. So giving ACE inhibitors and wait for sometimes within 3 months you can give those medication. If he is not on this medication, you can start and give some time to see the potassium and see the hypertension control. Then you can add within 3 months the intermediate, action. So in 3 months, you can give, not at the same time, all of them, to give time to measure the effect. Because hyperkalemia, we know that it's effect for both of them, SGLT2, the phenylalanine non-steroidal, MRI, and ACE inhibitors. So if he is not on ACE inhibitor, I prefer to start with it first, or any RB or ACE inhibitors. Then after 1 month, if everything goes smooth, you can add another medication. So you have almost within 3 months, you can give those medication. They are not included.
Some of the primary care physicians, they are afraid of starting SGLT2, or when they start SGLT2, there is a drop in the EGFR in the first 2-3 months,
Yes, that's
but
true.
but we
The
have
drop in
reassured them.
GFR is very limited,
Yes.
and almost with time it will be stable. So this drop is acceptable, almost up to 5%. I cannot remember, but with a small percentage, yes, it's acceptable to have a drop in EGFR just at the start. Then it will be stabilized, but the albuminuria will improve, and this is our target, to improve at least 30% of albuminuria.
Excellent. I think you have answered the question which was supposed to go to Dr. Ahmed. Since albumin reduction become a therapeutic target, what percentage reduction in UASCR do you personally consider clinically meaningful, Dr. Ahmed? You
Yeah,
said, I think 30.
yeah, as
Okay.
mentioned by Dr. Abdullah, and also in our
Yeah.
presentation, it was around 30%. So,
30%.
which is a great impact on cardiovascular risk even.
Okay. And how would you manage, Dr. Ahmed, those patients with a CKD who cannot tolerate ACE inhibitors and ARBs, because of the cough, and it happens many times that we cannot continue prescribing this medication for them, but still they have significant albuminuria. So we have to go for SGLT2 and firinose and omitting these ACE inhibitors, for example.
Yeah, sure. If the blood pressure is well controlled, so we have other agents, which is SGLT2 inhibitors, firinone, and GLP-1 receptor agonists with an evidence that can be cardiorenal protective.
All right, I think we are approaching the end because the other questions are almost repeated. So I would like to conclude, but before that, I would like to thank you all for attending these sessions. And I would like to thank our distinguished speakers and you as a participant for the valuable insights and session. And before we conclude, I would like just to summarize some of the take-home message which has been said elegantly by our speakers. So I would like to mention that chronic kidney disease is one of the most serious and common complication of type 2 diabetes, like any other complication, but this is a special complication that deserve a lot of efforts from our side and a lot of courageous attitude to manage those patients in early stage. So the primary care physicians, we have been positioned in a very special role to screen, to diagnose, to treat, and then to refer our patients. But we have to know our limitation. As we said, stage 3A, there is a red line, and after then, from my own experience, I usually refer my patient to the nephrologist and the colleague. So routine assessment of eGFR and urine albumin creatinine ratio should become the standard practice in diabetic care. And you will not be able to provide the patient state-of-art of management of diabetes without doing the eGFR and UACR, and early intervention through optimizing the glycemic control, the blood pressure, the cholesterol. So we have to treat the patient in total in a holistic approach, as said by Dr. Abdullah. So you don't have to treat the kidney, ignoring that there is other elements has to be controlled, and even the smoking, weight reductions, and so take the patient in total as a whole to manage them and try to implement the patient-centric approach. So whatever you do is put your patient in the center, and whatever you do will goes around the best interest of your patients. And we have to remember that we are living in the era of multidisciplinary approach. So we are not working alone, but we are working in a support with our other colleagues like endocrinology, cardiology, and even nephrology, and diabetic educators, psychologists, dietitians, and everyone should have a role in the management of the patient with the diabetes and chronic kidney disease. And most importantly, timely action. So time counts. So early screening is very important because this will change the landscape of the complication. We cannot stop the we cannot reverse the complication, but at least we can delay the complications. And we know that diabetes is a progressive disease. What we do just to delay the complication and make the life more appealing for the patients by improving the quality of life. So, ladies and gentlemen, I hope that today our discussions with our experts insight was very supportive to us to have this kind of wealth of information and to have this kind of expertise and the clinical practical recommendation from our two speakers will be quite appealing for us to carry along with us tomorrow onward to implement in our day-to-day practice and make the change that we would like to do. So I would like to mention it's all about working hard. It's about working better this time. So keep your eyes quite widely open to screen the patients and to identify those patients at risk. So with this, ladies and gentlemen, I would like to conclude, and I would like on behalf of you thank our guest speaker, Dr. Abdullah, Dr. Ahmed, for the wonderful, insightful, rich informations that we have gained today. A special thanks goes to Bayer for their wonderful contributions to bring us in this wealthy and healthy and rich scientific events. Special thanks goes again to ملتقى الخبرات لتنظيم المعارض والمؤتمرات, and all the thanks for you, ladies and gentlemen, for being with us today. We have more than 700 attendees, and with this we will conclude. May Allah bless all of us and make what we have delivered today علم نافع وعمل صالح لخدمة مجتمعنا ولخدمة بلدنا بإذن الله. شكرا لكم جميعا ونلتقي على خير بإذن الله. لكم أطيب التحايا. السلام عليكم ورحمة الله وبركاته. يعطيكم العافية.
فيك إن شاء الله.
شكرا لكم، يعطيكم الف عافيه.
شكرا دكتور أحمد.
شكرا جزاكم
شكرا
الله
جزيلا
خير.
لكم جميعا.
شكرا، نلتقي على خير إن شاء الله.
أنا استمتعت بالكلام الجميل اللي قلتوه، والله يعني كلام رائع. وأنا يعني سبحان الله هي في كل خطوة